There is an infectious disease affecting people all around the world and was responsible for more than 1 million deaths globally in 2020. If you had to guess, maybe you would think it was COVID-19. Well, think again, because it's a disease that was first discovered in the 1800s called tuberculosis. In this episode, we'll be speaking with two guests from Stop TB Canada about why we still need to be concerned about tuberculosis and the urgent need to prioritize programs targeted to the prevention, control, and elimination of this disease.
This is the Public Health Insight Podcast.
Before we move on, it is important to note that the views expressed in this podcast are our own and do not represent any of the organizations we work for or are affiliated with.
You're listening to the Public Health Insight Podcast, your go-to space for all things public health and global health, from the Sustainable Development Goals to the social determinants of health, as well as interesting dialogues about the diverse career opportunities that exist in these fields. Remember to subscribe to the podcast and leave us a rating on Apple Podcasts and Spotify so other people like you can benefit from our content.
My name is LaShawn, your host for this episode, alongside with my co-host, Gordon, and our guests, co-chairs from Stop TB Canada, Dr. Elizabeth Ray and Tina Campbell. Dr. Elizabeth Ray has been working as an Associate Medical Officer of Health with the Tuberculosis Program at Toronto Public Health since 2005. She is one of the authors of the 2013 Canadian TB Standards and has been involved in TB policy issues in Canada for many years. Our second guest, Tina Campbell, is an Indigenous woman of Cree ancestry and lived a majority of her life in Nunavut. Tina became a registered nurse in 2013 and continued work as a TB nurse for 6 years, where her main roles were in case management, contact tracing, and surveillance. She then continued as a territorial TB educator for a year, where she provided training, orientation, and TB education to staff. Since September 2019, she serves in the TB advisor role for the Northern Intertribal Health Authority. Dr. Ray and Tina, welcome to the Public Health Insight Podcast.
Thanks for having us.
Awesome. So thank you so much for joining us. And I want to first start off with Dr. Ray. So like I mentioned, you're currently serving as the Associate Medical Officer of Health with the Tuberculosis Program at Toronto Public Health. So can you tell us a bit about your day-to-day role and more about the TB program at the health unit?
Sure. So I'm an Associate Medical Officer of Health, which means I'm a public health physician. And so I lead the Toronto Public Health TB program, which is it's actually the largest TB program in Canada. There are about 300 people every year who get sick with TB in Toronto. And along with them, something like 2,000 people who are contacts of those infectious cases who themselves need medical care and follow-up. And another round about 2,000 people who are referred to Toronto Public Health by Immigration Canada for some TB follow-up after they come to Canada. It's a big program. In pre-COVID times, that means a team of about 70 people, public health nurses, TB outreach workers, a little group of clerks who do nothing but handle TB drug orders. So kind of a mix of staff, an epidemiologist, 2 social workers, and kind of behind that, people like, communications and graphic design people that are more kind of public health unit staff, not specifically with the TB program. Broadly speaking, our job is to prevent TB in people who are not currently sick with TB. So that might be working on advocacy around determinants of health that contribute to developing TB. So homelessness, for example, overcrowding, those are the kinds of things that can easily lead to rapid transmission of TB. If somebody in a homeless shelter, for example, has TB, they're around a lot of people in close quarters. But also supporting preventive treatment for people who have TB infection but are not sick. And especially supporting people who do have TB illness to get all the way through treatment. It's no fun. It's a long treatment. It involves a lot of medications. People can sometimes be very sick at the beginning of it. And it's kind of a socially fraught illness. So there's a lot of social and emotional kind of things tangled up with TB. And in Toronto, it's like 95% of people who get sick with TB in Toronto were born or lived outside of Canada, and that's usually where they picked up their TB. So this all happens in a big cultural mix. So all of those language and culture and social ideas about health and about TB are a big, big part of working with it. And of course, we also do a lot of work with the treating clinicians who are actually, prescribing medicines and ordering chest x-rays and that kind of stuff. And with organizations or facilities where TB happens. So hospitals, shelters, schools sometimes, or workplaces if we're doing contact follow-up there.
Awesome. That was very insightful on that sort of day-to-day. I didn't realize how big the program was and how many staff are dedicated to that specific program. So that just shows how labor-intensive and how important that work is. So Tina, I'm curious to hear from you. You're currently the TB advisor for the Northern Intertribal Health Authority. So talk us through what your day-to-day work looks like there.
Yeah, so before I start speaking, I just wanted to acknowledge that I am talking to you today from Treaty 6, the traditional territory of the Cree and the homeland of the Métis people. This is where I reside and work. So I'm the TB advisor at Northern Intertribal Health Authority, or NITHA for short. So NITHA is the only First Nations organization of its kind in the country. It's comprised of Prince Albert Grand Council, Meadow Lake Tribal Council, Peter Ballantine Cree Nation, and Lac La Range Indian Band. This partnership kind of joined together in 1998, and NITHA delivers a service known as Third Level. So essentially, we help our partners, if it's developing policies, educational resources, advisory services. But our TB program is unique because our nurses, we have 4 currently full-time TB nurses that work under our program. And we serve 33 First Nations on-reserve communities. So that's a really small team to serve such a big population. There's about 55,000 people within our jurisdiction. So day to day, my position, I get calls from community health programs, health directors, if they need any resources for TB for their communities or want any updates on the TB activity in their regions. Currently, we do have some tuberculosis outbreaks, and I believe that they're a direct result of the impact that COVID-19 has had on our TB programming. And our nurses are quite busy. They've been traveling consistently to communities since October. Prior to that, they were we'd only go into the communities if it was absolutely needed, just because there was continued to be COVID outbreaks within different communities. So I coordinate the outbreak responses, any travel, and also organize any TB program worker training. So our TB program workers are community members that are in each community. We're very lucky to have them. They're community members. People know them. People trust them. They speak the language, whether it be Cree or Dene, depending on what community they reside in. They've been really carrying the TB programs in the communities during COVID. And, there was a lot of reassurance that we had to give as well, because people were scared of COVID and going into houses and having people come into their houses. So we've been pretty busy. I'm really lucky to have the TB nurses that I do, because they're extremely hardworking, and the TB program is huge. So in Saskatchewan, the clinical part is run by the province, and it's called Saskatchewan TB Prevention and Control, and it's works out of Saskatoon. So we have a bunch of nurse clinicians assigned to different communities and different areas in our jurisdiction. So our nurses work in collaboration with them to organize, any training, any contact investigations that's needed in the communities, because we have short staff. We're short-staffed in a majority of our communities. And of course, because of COVID, everybody is extremely exhausted and burnt out. So we often are asked by the communities to come in and do a majority of their TB program work. And some communities, they have up to a couple thousand people, so it can get really busy, and our nurses are working long hours in the communities as well. So I'm sure I have more to add, but that's pretty much what a day looks like for me.
Yeah, for sure. You two seem like you're super busy at work and you're doing really important things, collaborating with so many different people and, really stretching the resources to, make as much positive impact as possible. And what I also know is that you both are co-chairs of Stop TB Canada. Can you tell me a bit about what that is and, what it does and why does it exist?
So Stop TB Canada is a national advocacy organization. It was started about 20 years ago. And the goal is basically to advocate for an end to tuberculosis domestically here in Canada, as well as globally. There's a number of different Stop TB country-specific organizations around the world. Stop TB India, Stop TB USA, Stop TB Mexico, and there's also an international Stop TB partnership, which doesn't exactly coordinate the country-specific organizations are independent, but there is a big role in terms of global advocacy that the international Stop TB partnership plays, as well as some really major pieces like a wonderful initiative like the Global Drug Facility, which is the world's largest purchaser of TB drugs, and acts as a low-cost, basically warehouse and supply chain and infrastructure support for low and middle income countries to be able to access high quality TB medications at low cost, including multi-drug resistant TB medications.
Mm-hmm. That's fantastic. And I really like that overarching goal of ending TB domestically and globally. So having that consideration of both. And it makes sense because, as you mentioned earlier, there's a lot of people traveling across the world into Canada, and there has to be that consideration of this interconnectivity between different countries and different regions in the world. So I thought that was very interesting.
Yeah, I mean, Canada has, Tina can speak to this, right? There's Indigenous Canadians who are like here forever, but the rest of us came from elsewhere, right? I work in Toronto where half of us were born outside of Canada. I'm an immigrant myself. So it's maybe not surprising given those demographics that so much of our TB in Toronto is connected to the global pandemic. Nationally, that's about 70% of people who get sick with TB were born outside Canada and presumably got their original infection, were well when they came to Canada. And for whatever reason, often years later, it becomes active and they fall sick. But there's another 20% among Indigenous Canadians. And Tina's the one to speak to this, but that 20% is entirely Canada's, shame that it's still there and entirely on Canada to fix. That's not something to say, oh, well, it's this big global, giant problem elsewhere. That's here. That's entirely on us.
Yeah, so this is my second year with the Stop TB Canada Steering Committee. Last year I joined, and it's a network of varying professions from across Canada, but our main focus and goal together is TB elimination. And it's opened up a lot of doors, and I've learned quite a bit within the last year from all these individuals. They're all very passionate about TB elimination as well. So I'm very grateful to be a part of it. And then, I was nominated and appointed as the co-chair alongside Elizabeth, and I've been working in TB since 2010. And I knew of Elizabeth quite a long time ago when I was working in Nunavut. So she's somebody that I've always looked up to. So sitting beside her is a really amazing thing to be doing. So since I've started as well, I've been able to speak to a lot of Indigenous issues, and I've been reached out to talk about importance of cultural orientation and awareness training, specifically in regards to the history of tuberculosis and the Indigenous population. So I can offer a little bit of background for that. So TB came to Canada with European settlers in the 1700s. And then in 1867, tuberculosis became the leading cause of death in Canada. And then, of course, as they learned that TB was infectious, they tried to isolate those infected in sanatoriums. And then, of course, as time, progressed and, residential schools came about and TB sanatoriums and Indian hospitals, a lot of negative and tragic events took place during that time frame. Reserve communities were created, and so to this day, I find that learning about the history and how things were in these residential schools, so poor ventilation, poor sanitization, malnutrition, all that kind of thing. So the isolation of reserve communities and northern remote communities, they do still face inadequate nutrition and housing issues as well, like poor ventilation, overcrowding. So that still today has that creation of increased disease transmission, especially with something like tuberculosis. So I think that still remains a huge issue with TB and how there's so many TB cases within our Indigenous populations today. So,
wow, thanks for giving us the context on the history and the background of the disease. And now I'm wondering if we could talk a little bit more about what is tuberculosis and what are those specific features or characteristics of this disease that has made it stick around for such a long time.
So TB, tuberculosis, is a disease caused by Mycobacterium tuberculosis bacillus. It usually affects the lungs, but it can affect any other part of your body, like your bones, joints, kidneys, your brain, and reproductive organs. So it is a slow-growing bacteria. And often people who are infected with the TB germ, since it's slow-growing bacteria, they don't know that they have it until they start becoming unwell with symptoms. And usually by the time you experience symptoms like a cough, then at that point you have the ability to spread it to others. There's two main types of TB, which is latent TB and active TB. So when somebody breathes in the TB germ, about 90% of the population, your body will kind of lock it up and it'll stay in this latent or sleeping form. There's always a potential for it to become or turn into active TB. And usually your risk of that happening is higher within the first 2 years of becoming infected. And then they offer treatment for latent TB, which can be anywhere from 3 months to 9 months, depending on what regime that you're prescribed. And I found, in my experience, it's hard to convince people to take treatment for latent TB, just because if you're not feeling unwell, then people often find it hard to justify taking medication, especially for months at a time. But if you don't treat the latent TB, there's always that chance in your lifetime that it can progress to active TB. And some risk factors with that are, if you become immunocompromised, develop other health conditions, and as you grow older as well. And with active TB, so about 5% of the population, 5 to 10%, go on to develop active TB right after becoming infected. And, people with active TB will have cough, fever, night sweats, loss of appetite, unexplained weight loss. And then, of course, if active TB is left untreated, it can become quite fatal. So there are some risk factors to developing active TB. And if you have HIV infection, chronic renal failure, cancer, diabetes, if you have poor nutrition habits, if you smoke cigarettes, and if you're under the age of 5. So The pediatric population, once they're exposed, they have a higher risk of developing life-threatening forms of TBs. That's where, where you have high incidences of TB in these communities, it's really important that people have some sort of pediatric process when they're screening clients who come in who are symptomatic. And I think that's something too that needs to be more known and more enforced in communities with TBs.
To follow up on Tina's point that it can be really severe. Without treatment, the natural history of TB is that half of people will die within 2 years of first developing symptoms. So before the first real treatments for TB were developed, like the first effective medication was developed during World War II. There hasn't been effective medical treatment for TB for even 100 years. And TB's been around for millennia before that, right? So for most of our human history, TB has been something that people die from. And they die slowly and sometimes dramatically, right? Tina was saying it's a slow-growing bacteria. It's a slow illness. People can be sick for months and months, sometimes years before they die. And there's this kind of classic historical picture of people wasting away and coughing up blood. And that is a picture of what fatal TB can look like without treatment. So it still kills 1.5 million people a year globally, generally in places where it's difficult to access diagnosis and treatment. And that, dramatic, fatal impression of TB is still something that's very much part of cultural and family histories. When you talk to people, no matter what part of the world they're from, that's often the kind of thing that will come to mind. And it's one of the reasons why people can be quite frightened of TB. It's one of the reasons why sometimes people can even be reluctant to take latent TB treatment, because it's like, well, I'm not sick. I don't want to have something that terrifying. So if I'm not sick, I'm good. Thanks. Bye.
I was going to ask you about, both of you can chime in on this too. So one, do we screen for latent TB? Is it different from finding active TB? And then two, what are the difference in the treatment regimens for active versus latent? Is one longer than the other? And I guess if latent is just as long as active, is there less of an incentive for someone who has latent to want to pursue treatment? Just trying to understand the underlying motivations for people's decisions to get treated or not.
So in Canada, there's no kind of routine screening for tuberculosis. There used to be widespread across the country. Every school child would get a TB skin test when they started school, and often again in high school. That was rolled back decades and decades ago, except in some very high incidence, high risk communities that tend to be, and again, Tina can speak to this from her personal experience as a TB nurse, in some of working against TB in some of those communities. Where TB screening does still happen is as part of the immigration process. So when you apply to immigrate to Canada, whether it's on a student visa or citizenship, landed status, whatever, a TB checkup is part of that. At the moment, it really just checks for TB in the lungs, because that's the only part that would be infectious, right? Like the idea is to prevent a situation where someone would step off the plane and be infectious to people living in Canada. So most people the immigration exam would not include a check for latent TB, only for active TB in the lungs. So there again, it's not checking for active TB in your kidneys or your bones, just in the lungs. If you do get diagnosed with TB on an immigration medical exam, it doesn't disqualify you, but it does put your immigration application on hold until you finish TB treatment.
Oh, I see.
Wherever you are. So it can certainly delay people's immigration process if you get diagnosed with active TB.
And how long does that typically take, the treatment aspect of it?
Right. So treatment for active TB is a minimum of 6 months with 4 antibiotics, special TB-specific antibiotics. People who have more severe disease, it could be as long as 9 months or 12 months. If you have multi-drug resistant TB, it can be even longer because in that case, you've got a strain of TB that's resistant to the main medication. So now you're looking at the backup medications, which can, they're backup because they're not as fast acting, right? As effective as the main drugs. And they can have more side effects. They're more expensive. Some of them can have to be given by IV or injection. We can talk about that. Like treatments for TB are improving, especially for multi-drug resistant TB. So there's some really wonderful prospects there to make TB treatment better. But it's still arduous right now.
Yeah, so I can talk a little bit about my experience both in Nunavut and Saskatchewan. So when I worked in Nunavut, I actually worked within a TB clinic. So they had a designated clinic dedicated to tuberculosis. And of course, part of my job was case managing clients who had active TB or latent TB. So our screening process is up there. They did have, pediatric screening. They offered the BCG vaccine at birth up there as well, which protects you for the first 2 years of your life from life-threatening forms of TB. And then before children enter the school system, so when they're 4 years old, they do a preschool screen, and they also get screened for tuberculosis at that point as well. So that, and then once, you do a tuberculin skin test, and then once somebody is found to be positive, then you do a workup and we rule out active TB first, and then we offer preventative treatment for latent tuberculosis infection. When we're doing contact investigations, so when we identify a client with active TB, we have to go in and obviously establish a relationship with the client and kind of identify people in their lives, in their homes, in their workplace, social circles who've been potentially exposed to active TB. And then we screen them the same way we do a tuberculin skin test if they're eligible, if they haven't had a previous positive in the past. We do chest x-rays and we do sputum and we do blood work. And then, of course, if they're identified to have active TB, they're offered active TB treatment. If they're identified to not be active TB, they're offered latent TB treatment as well. So for me, when I started working with TB back in 2010, it was after my first year of nursing school, and we actually had to do an immunization workup and have all of our stuff up to date. So I had lived in the north for most of my life in Iqaluit at that point. From 2001. So this was 2010. So I had lived there for about 9 years, and I got a tuberculin skin test and it was actually positive. So I was diagnosed with latent TB infection and I was offered preventative treatment, and I took it. So they do treatment for TB throughout Canada. The standard is through direct observed therapy or DOT. So a healthcare provider who's trained gives you this medication. So I was on this medication twice a week for 9 months. So I was a nursing student, of course. I asked all the questions, why can't I take this medication on my own? And then learning about how the TB programming works, it made sense to have, that interaction with the healthcare system. Plus, TB medication too can be pretty harsh on your liver. So having that constant monitoring and engagement with the healthcare system was good to make sure that your treatment was safe. But it was really hard. I blame that today for me finding it difficult to swallow the smallest pills, because those pills are big and chalky. In Saskatchewan, when I moved down here, I found that they didn't I believe they stopped, I can't remember the exact year they stopped giving the BCG at birth, but it's been a while. And they stopped pediatric screening in 2019 because they had done a study within our organization communities that they were only finding about 1 or 2 positive TSTs from doing all this extensive pediatric screening. So what they implemented was increased pediatric screening when there's a case of active TB. So, a client with active TB. So if they're identified, then our goal as TB nurses is to go in and ensure that we identify anybody under the age of 5 or any children in the house that may be at a higher risk of TB progressing into active TB after exposure. So that's how Saskatchewan is different from Nunavut, as opposed to, having a designated TB clinic where we do screening almost, every day for people. So, and in terms of treatment, it's really hard to convince people to take treatment for latent TB infection. That's where education and that relationship comes into play and is really important. I find that the more education you give somebody and, weighing the benefits to the risks, and also, somebody in TB care or TB treatment is often with you for months and months and months, as Elizabeth has stated. So the care approach too, it has to be a huge collaboration, and TB programs too, especially in Indigenous populations, have an incentive program. So we're there to try and motivate and keep these clients engaged, and because our goal is treatment completion and TB cure. So we work alongside not only the client, but other areas of healthcare as well too. So
fantastic. And it's so great hearing more about the programs, screening of TB, the active and latent forms, the real nitty-gritty of what goes on behind the scenes, and the contact tracing aspect. Now that we talked about that, I want to know a little bit more, because surely the COVID-19 pandemic affected these programs, the delivery, the capacity, maybe the drug chain supply aspects of the different aspects of your program. So can you tell me a bit about how maybe these programs were disrupted by COVID-19, whether it's at the local, national, or even global context?
Sure. So I said in Toronto that the TB team is about 70 people. 3/4 of our team got redeployed to COVID. I got entirely redeployed to COVID. I've been working with COVID long-term care outbreaks for 2 years. So that means a lot of core TB work that hasn't happened for 2 years. It's really been reduced to a much more bare bones support for people who with TB illness, supporting them getting through treatment. Almost no contact follow-up at all for 2 years. And that's really it. So none of that other latent TB support, the immigration follow-up care, none of that. None of the TB outreach, education stuff, World TB Day activities have pretty much not happened, other than, we light up the CN Tower and the Toronto, that kind of illuminated Toronto sign, gets lit up red. But that's it. Like, we usually have a big event every year for World TB Day. Not possible. So even the level of support that we've been able to do for people ill with TB has been less than we would normally be able to do, right? Like our social workers got redeployed. So the amount of help that you can give people with housing, getting them linked up to whatever income support they're eligible for, helping them get linked up with food support, or whatever kind of practical realities that they need to get solved if they're going to get through TB treatment successfully and be as healthy as they can. Our ability to do that has been very constrained. And the treatment support program that Tina talked about, directly observed therapy where there's someone actually working with every person who's in TB treatment. I guess this is kind of a good and bad thing. A lot of that traditionally has been done in person. So you meet with your TB nurse or outreach worker or support worker at home or in the park, like really wherever you want to meet. But the other way of doing that had started even long before COVID is doing it virtually. So over WhatsApp, for example, or some other kind of digital platform. And because of COVID, and also because we had lost a bunch of our TB staff who were redeployed to COVID, we switched a lot more quickly over to video support, which in some ways is great, right? Like that meant that there was someone that people could still be connected to right through TB treatment. Most people have a phone, like a smartphone, and we'll give people a phone if they don't, to be able to do that video DOT connection. But it does mean, like Tina's right, like in Toronto as well, staff were worried about going into people's homes as much, especially at the beginning of COVID when we weren't as clear about what kind of PPE before there was a vaccine. And the people who were in the home were worried about having, visitors coming in, especially because these were visitors who were taking care of lots of other people, right? So lots of worries about COVID transmission. But that meant that people who really benefited either from having a nurse, like a trained nurse, to come and help with side effects, with managing their diabetes while they're in the middle of treatment. Like there's a lot of medical complexities that can happen, that having that really close nursing support can make a big difference for managing complications and side effects. It was a lot harder for us to do that, those in-person visits. And there's also a big piece often in terms of kind of social support. Like both Tina and I have talked about some of the emotional, social dimensions of having TB. And then you throw a COVID pandemic on top of it that can make people feel even more isolated. Having someone who's going to be there and listen to you and be part of helping you get through treatment no matter what is really helpful for anybody with a chronic disease. There's an end to TB treatment, but it's still a long time. It is a little bit like a chronic disease that way. So that kind of support has been a lot harder during COVID, with what's essentially a staffing shortage, right? With so many people redeployed.
Well, yeah, thanks so much for sharing. And I'd love to hear from you, Tina, as well, because I know that on top of the COVID-19 pandemic, you have TB outbreaks in many Indigenous communities. And oftentimes in these communities, like you mentioned earlier, there's a lot of housing challenges and overcrowding that can lead to complexities when you're talking about isolations from COVID-19 protocols. And I'm guessing as well, some sort of isolation with TB protocols and contact tracing. Can you talk a bit about some of the complexities that COVID brought about?
Yeah, so as Elizabeth had mentioned, in her workplace, my entire team was deployed to help with some COVID surge, whether it be keeping track of active cases and doing contact tracing and daily monitoring of positive COVID cases, and then going into the community doing screening, helping out with immunizations as well. So, my role throughout the pandemic, of course, I remained in the TB advisor role, but I was doing mostly COVID stuff because our trips into the communities were put to a halt. There was only, emergent and necessary travel going into the communities, and, you had to get screened and then had to get a letter from our MHO for approval to go into these communities. And then our provincial TB program as well, a majority of them, were assisting with COVID as well. And then our contact investigations became, we'll focus on the household since we can't go into the communities to help do a wide contact investigation. And I think because of that, a lot of people were missed. A lot of people that were exposed and were high risk were kind of missed throughout those couple years. So I think that is a reason why we're seeing a lot of TB clients and a lot of positive TB diagnosis today because of all the deployment of all our resources into COVID. And it was interesting too is while our nurses were deployed into the communities, we were asked while we were doing home visits to also screen for COVID. So then, we're coming out of the community and we're like, okay, so if somebody is screened for COVID and they're negative for COVID, is anybody screening them for TB? And, well, no, they weren't. We did find a couple, clients who had been going to the health center a couple of times and negative COVID, okay, but they actually ended up having tuberculosis. So, it's a huge impact. COVID has had a huge impact, and it's becoming more apparent as time goes on and we have more cases diagnosed. So
there's one sort of interesting thing to think about. I don't think we really have the data to know much about how this actually played out yet, but one of the things to think about is, have COVID restrictions slowed down transmission of TB? Right? There's a lot of people working from home. So that means if I have active TB and I can work from home, I'm not going to infect my coworkers over a Zoom meeting, right? Things like that. But a lot of people haven't been able to work from home. And when you think about who is at risk for TB, and you think, okay, well, people who migrated more recently to Canada, people who are living in reserve communities with really crowded housing, people who already live in multi-generational households, right? A lot of those people do work that you still have to go to work, right? So lots of those essential services that we talked about during COVID, a lot of those have involved people who come from, broadly speaking, communities that may have a higher risk of TB in the background as well. And all the COVID restrictions in the world don't do anything to solve overcrowded housing problems. So transmission within households is, COVID restrictions aren't going to do anything about the risk in households. It's too early to really know whether those things have made a difference, but there's some real reasons in Canada where they may not have so much. So that's something else to think about. And I think one of the other pieces is, people have been worried enough about going into hospitals full of COVID patients. If I go to Emerge, maybe I'll catch COVID, right? So there's real worries on an anecdotal level. We think that a bunch of people who got sick with TB over the last couple of years were sick for longer before they sought medical care because they were worried about going to a hospital, or, it was difficult to find a doctor who would see you in person, right? A lot of medical care was more difficult to access during COVID. And then again, kind of what Tina's talking about, right? You show up with cough and a fever over the last 2 years. The very first thing people are going to do is say, oh, maybe it's COVID. So there's, it's a bit of a worry that, has TB kind of fallen off the radar a little bit. And that might be part of why people seem to have been more ill by the time they actually get diagnosed.
Yeah, I'll add to that, there's a lot of remote communities, and a lot of remote communities have high Indigenous population. So their access to care might already be, limited. They might not have a hospital in their community, so they might have to get flown out. And then that kind of makes people hesitant to seek care as well, especially if they're aware of TB history. And with COVID restrictions as well, if you have somebody going in and getting tested for COVID and they're negative, then okay, they're going to continue to go to their grandmas or their uncles or their, because they're cleared of COVID, and nobody is thinking about, oh, maybe you have tuberculosis. Maybe we should keep you home, until we figure this out. But that wasn't happening. And as a result, too, we have been seeing, people coming in being diagnosed with TB at very advanced stages of diseases. TB meningitis, disseminated TB that, has spread to other organs of your body. And so I think that can be viewed too as a result of all the COVID restrictions and the impact that it's had on TB as well.
One other thing I wanted to add to that about, talking about transmission in outside of the home, or in kind of more public places or workplaces, that kind of thing, is masking. TB is airborne. So that means if I have TB and I'm wearing a mask, that's going to cut down. It won't totally prevent, but it is going to cut down on my ability to get lots of TB bacteria out into the air where somebody else can breathe it. So that is kind of an interesting one to. It's a sort of an unknown factor right now, how much of an impact that will make outside of households. I want to say again, like the biggest risk situation is always within households. Those are the people that we, sleep with, eat with, hang out with, day in, day out, and probably even more during COVID. So, the worry about making sure that households and family members get the best TB care possible is a real, that has to be way up there in terms of access to care.
Mm-hmm. Yeah, thanks for elaborating on that. I was going to ask you about, because we know things like the flu, we were seeing that the rates are dropping with flu, and the flu-related deaths are dropping. So I was basically going to ask you, public health measures like masking, physical distancing, ventilation, what impact did that have? But you're making the case, both of you, that, well, the close contacts that we're worried about are people living together, family members. So it's not so much you're at the grocery store and someone walks by you and you get TB. It's more the people that you're around in your daily circles that you're worried about.
Yeah, it's prolonged or frequent interaction with somebody that leads to TB transmission. It's not, we worry about picking up COVID with a 15 minute at close quarters kind of thing. For TB, it tends to be much longer exposures and interactions.
One of the things that I really wanted to know, given we're talking about all these challenges and with COVID-19 and all the inherent challenges present with TB itself, can you talk a little bit about the state of the current TB surveillance systems in Canada and the various challenges this poses to TB programming in light of what we talked about with COVID-19?
So during COVID, we've gotten really used to, opening up news sites and looking for today's COVID count, like day-to-day, instant, real-time updates on COVID cases and COVID immunization coverage and hospital and ICU status and all of that. That kind of surveillance depends entirely on having real-time electronic health surveillance data. So interconnected healthcare databases. We don't have that for TB. We absolutely do not. The last So this is a digression into, constitutional systems in Canada, right? So under the Canadian Constitution, health is a provincial and territorial mandate, not a federal mandate. So that means de facto, we don't have a national TB program or system. We have 13 individual provincial and territorial TB programs, plus layered on top of that, Indigenous Services Canada, which is to some extent a 14th sort of TB program. Not all of those even have electronic TB databases themselves, or well-functioning ones. Some of that Tina should speak to. Some of that has to do with internet access in remote areas, right? Like, how do you actually make an electronic system work without a robust infrastructure? But even then, we don't have remotely a timely way of gathering it all up at the national level. The last national TB data was published in 2019, and the content was 2017 TB data. So the last national level snapshot of what is happening with TB in Canada was 5 years ago. We have 5-year-old data for TB to work with to say, well, so has the pandemic had any impact? The short answer is, we don't know. You might know at a very local level, like Tina knows exactly what is happening in her communities, because she and the team that she works with work directly with those people. And to some extent, that's the same in Toronto, though I will say with so few staff, I can't tell you how many contacts there have been because we haven't been able to do the contact follow-up, so we haven't entered the contact data. So at the national level, it's incredibly archaically slow. Really totally needs a digital modernization revamp. Also needs way more epidemiology support. Like, even that 2019 report was bare bones. It was provincial territorial breakdown, age, gender, that's almost it. So none of the kind of detailed information that I would need in Toronto or Tina would need in Northern Saskatchewan to be able to say, what's gone awry, which groups are specifically kind of falling between the cracks that we need to do more to support. None of that kind of more detailed epidemiologic analysis. And in Canada, that would need to happen not just at the national level, so that we're all pulling in the same direction to national TB elimination, but that also needs to happen within every TB program, right? So that means within Ontario needs to do that kind of detailed status update to know where we're at. So does Toronto, so does Saskatchewan. So there's a lot of even where are we at catching up to do.
I'll just add a couple points to that as well. So with First Nations communities, they have our program, NITHA, is funded by Indigenous Services. So we, of course, oversee the First Nations communities in Northern Saskatchewan. And what I've noticed is every community is different. They have different ways of storing their data, who has access to it, and rightly so, it's their information. But it's hard to get concrete numbers. I find that it's hard to get accurate numbers of LTBI diagnoses and before the pandemic, our organization actually we were going to do a research project and try and identify these LTBI numbers and clients and then offer them preventative treatment, because of course you can't eliminate TB without eliminating, the whole big picture, active cases and latent TB cases. I find it so surprising and frustrating that, our TB data is over 5 years old. How are we going to make any changes if we don't have updated statistics? I honestly think that it needs to be more of a priority, nationally and provincially and territorially to get this data out there, because that's the only way that we're going to be able to make, effective changes, is if we know what's going on in our country, in our Indigenous communities, in our remote communities, in our, high rates of cases in immigrant population as well.
Yeah, that's astonishing considering, if I remember correctly, TB is, in terms of the leading causes of death, the 13th overall. And then when you talk about infectious diseases, it's only second to COVID, I believe, globally. So it's just, and I would imagine this is probably a challenge with other countries as well. So I wanted to hear from you two, what actions need to happen at the provincial level, local level, or even the national level for us to get one step closer to stopping TB?
Well, I think one of the most immediate pieces is to staff back up, right? TB programs have been, for good reasons. I'm not saying that, the COVID pandemic hasn't been a real urgent health issue. But nevertheless, it's difficult to do anything if you don't have people. So staffing back up the TB programs, I think, is a real urgency. I do feel like some of the things that have really, COVID has made really obvious how the interconnected digital healthcare surveillance, electronic surveillance, and interoperable health databases that talk to each other, how critical those are to be able to guide and tailor concrete actions. I think applying those lessons to TB urgently is really important. I think publicly renewing the commitments that were made, especially at the national level, to TB elimination, and again, especially for TB elimination for Indigenous Canadians, to renew that commitment and put budgets behind it, is essential. We're not going to get anywhere without that. And I think as well, because actual on-the-ground TB care and prevention work happens at the provincial and territorial level, it can't just be a federal commitment. It really needs to be all of us committing together and working in the same direction. So that, in a pragmatic way, that means federal and provincial and territorial and Indigenous Services Canada actually getting together and coming up with a common plan, not, a fragmented, siloed, some people do have a plan, other people don't, and on the ground, people like, TB nurses and physicians in the TB clinics and outreach workers are just doing incredibly good and important work, but you can't solve TB without an infrastructure.
There's also the need to, for territorial, provincial organizations, programming, health centers, communities, for those health directors or those managers to put TB as a priority, especially if there's high incidence within their communities. It's being a TB program. We're a TB program for a reason, because there's high numbers of TB in our communities. So our TB nurses, like I said, 33 First Nations, we're busy. We're very busy supporting everybody. And then we're often called to do frontline services in these communities. And when we're not in there, the TB program isn't even being focused on, really. So I think making TB programming mandatory, that somebody in the community at every given day is dedicated to this TB program to ensure the continuity of care, and also to have support for our TB program workers who, are in the communities doing direct observed therapy and, talking to us on the phone when we're hundreds of kilometers away. And, it's we support them as much as we can, but it would really make a difference if these communities actually put TB as a priority and made it mandatory for somebody to cover these programs while we're not physically there. So in a way, like it really does have to start at the community level as well, and have that engagement. And a big part of our organization's job as well is to provide community education, and we haven't been able to do that because of COVID. So hopefully with, the numbers going down and restrictions easing, that we can start to get back on that education and awareness piece, and hopefully get more engagement from communities and leadership that way.
There's another piece I want to add to, what can we do? What can we do better? How can we get back on a better track and faster? There's a new edition of the Canadian TB Standards that is on track to be released on World TB Day this year, March 24th. And one of the things, or some of the things in that new Canadian TB Standards are new recommendations for shorter course latent TB treatments, and updated recommendations around treatment of multi-drug resistant TB. And those are really exciting opportunities. And much as we've been talking about how devastating COVID has been on TB care and TB programming, the fact that we're hopefully coming out of that pandemic, it feels like a chance to restart and reset a whole bunch of stuff for TB care. I do want to flag that a bunch of those medications that are talked about in those new Canadian TB standards are either not licensed in Canada, so you have to jump through incredible hoops to get them, despite them being core medication. Like, these are on the list of WHO essential medications, and they can be difficult to get in Canada. So harnessing Health Canada and the powers that be to make those medications truly accessible to all Canadians is another big piece I think we need to jump on. And there are also really encouraging, at least early developments in prospects for a new, better tuberculosis vaccine, and for even shorter TB treatment courses. And, if nothing else, COVID has proven that if we want to, the big collective we can put a ton of money and energy and resources into solving problems like coming up with a really effective COVID vaccine in the space of a year. We could do the same thing for TB. We haven't for decades, despite it being a WHO declared, global pandemic emergency since the 1990s. But we could. COVID's kind of a, case proof. So, okay, we can take some of that money we were pouring into COVID and say, there's another pandemic out there. And there's so many good things happening that when we talk about global budgets and, defense budgets and all that kind of thing, drops in the bucket really would make a massive difference in the lives of people that Tina and her team and us here in Toronto take care of.
Yeah, that whole vaccine thing, working from home, and then school being canceled. My son was around me pretty much 24/7 during the earlier days of the pandemic. And then, of course, once the COVID vaccine was created, he said, "Mom, do they have a vaccine for TB?" I said, "Well, they have one that's given at birth that covers you for the first 2 years." And he said, "Well, how come they came up with one so quickly for COVID? Why aren't they doing this for TB?" And I said, "I'm wondering the same thing." So, he was 9 at the time that he said that. So he's, a smart kid. But also talking about, medication and that accessibility. And I also have to say, too, that active TB is treated with at least 4 different antibiotics in pill form most of the time. Imagine giving 4 different antibiotics to a 1-year-old, a 2-year-old, moving up to 5 years old, it's extremely difficult. And I think that if more money was put into finding friendlier types of medication for children, I think that would make a huge difference as well, because, crushing up those pills, they taste awful. These poor kids have to endure at least 6 months of all that. So, I mean, just even starting with something as basic as that is getting easier to take medication or different forms, liquid or what have you, right? Better tasting, easier administration to kids would solve a big issue too.
Perfect. And it's so wonderful having this discussion. And I reflect back to when I was in grade 7, when I actually did one of my first classroom presentations, and it was on TB, tuberculosis. And so it's very interesting coming full circle and learning again back, after completing a master's and after going into public health and learning more and more about this. And I do have a suspicion that this podcast is going to be great, because I feel like a lot of people have forgotten about tuberculosis. Even though it's such an ancient disease, it's still around, and it's wreaking havoc in communities in Canada, specific provinces, and all around the world. So I'm so glad that we had the opportunity to talk to both of you, Dr. Ray and Tina. And thank you so much for coming on the podcast. We're so glad to have had you on today.
Thank you so much.
Thank you for listening to the Public Health Insight Podcast, your go-to space for informative conversations, inspiring community action. If you enjoy our podcast, be sure to subscribe and leave us a rating on Apple Podcasts or Spotify. See you in the next one.